Therapeutics of Leukemia and Lymphoma. Yesterday we discussed the drugs which are used in the management of leukemia. This includes alkylating agents, antimetabolites, microtubular inhibitors, cytotoxic antibiotics, some hormones, differential agents, retinoids and arsenic trioxides, and interferons. In Word file, I have attached Word file at the LMS. If you click on this name of the drug, you will be landing to the pharmacology informations related to the specific drug. Yesterday we discussed about this cyclophosphamide. Its adverse effect is hemorrhagic cystitis. And how to prevent this adverse effect? We have to give the mesna to mercaptoethane sulfonate. It is used for the prevention and treatment of hemorrhagic cystitis. This one table indicates the specific adverse effect of the drug, like cyclophosphamide having the hemorrhagic cystitis, cisplatin nephrosis, ototoxicity, busulfan pulmonary fibrosis, methotrexate, crystalluria, or maybe leads to acute renal failure, vincristine, neuropathy, doxorubicin, cardiotoxicity, bleomycin, pulmonary fibrosis, and asparaginase, pancreatitis. Yesterday we discussed about the treatment of the acute lymphoblastic leukemia, and the treatment of the acute lymphoblastic leukemia include the four stage: induction of complete remission, consolidation, maintenance, and the CNA prophylaxis. The drugs was VPDA for the induction of the complete remission, for the consolidation, VPD, and A is replaced by the ETC. For the maintenance, you need MMPV, and for the CNS prophylaxis, you need methotrexate for the 8 weeks. Treatment of chronic lymphocytic leukemia, for the induction of remission and the maintenance, you need same drug, fludarabine, which is the most effective single treatment, or you can prescribe COP or CHOP. For the induction of the remission and the consolidation, the same drug, fludarabine. And for the maintenance, you can provide the CHOP. Treatment of acute myeloblastic leukemia, AML, the cytarabine was the most effective single treatment, or you can give cytarabine plus idarubicin or hydroxyurea for the induction of remission. For the consolidation, you will prescribe same drug, cytarabine plus idarubicin, and there is no need for the maintenance. Treatment of chronic myelocytic leukemia, imatinib, the most effective single treatment and the standard first line therapy, or you can prescribe CH, that is cytarabine hydroxyurea. Consolidation not used generally in the clinical practice, and maintenance the same, but the dose is low. Today's objective of the lab is treatment of Hodgkin lymphoma and the non-Hodgkin lymphoma. The Hodgkin lymphoma generally includes the combination therapy. If there is a question for the OSP, give the treatment protocol for the Hodgkin lymphoma, just remember A, B, V, D. A, B, V, D, not A, B, C, D. Instead of A, B, C, D, remember A, B, V, D. A for adriamycin, and it is another name, second name for the doxorubicin. B for bleomycin, V for vinblastine, and D for dacarbazine. We have to prescribe 6 cycles of ABVD every 28 days. Every 28 days means near about 1 month. So this therapy for the Hodgkin lymphoma is last for 6 months, near about 6 months. And we have to give the 6 cycles, 6 dose. 6 cycles means we have to give 6 doses after every 28 days, and each dose or each cycle contain 4 drugs, that is ABVD. Generally, the Stanford Hospital in the UK, they developed their own regimen, Stanford V regimen, and then they have given the name for treatment of Hodgkin lymphoma is called Stanford V regimen. This is the a specific regimen of the Stanford Hospital, and it is generally divided into 12 weeks chemotherapy, which is generally given by the intravenous, followed by the radiation. So they have the protocol, they have the plan. If the patient wish to get this treatment from the Stanford Hospital, in the 1 week, 5 and 9, they will give miclorhythamine, doxorubicin, and vinblastine. We can say MDV. In the week 2, 4, 6, 8, 10, 12, they will give VB, vincristine, bleomycin, intravenous. In the week 3, 7, 11, they will give doxorubicin, vinblastine, etoposide for 2 days. Their protocol, their weeks are divided. Prednisone, prednisone is an oral steroid and is also part of the Stanford V regimen. Patient will take this drug every other day at home, means oral drug, and every other day means 1 day will be gap, like baad bukra for the duration of the treatment. In odd number weeks of the treatment, like the 1, 3, 5, 7, 9, 11, patient will have nausea. For that, they will give ondansetron. Ondansetron, it is a 5-HT receptor antagonist, serotonin receptor antagonist, and prevent the vomiting, nausea. Even number weeks, nausea is not much, and there is a one side effect of the bleomycin. The bleomycin will cause the fever up to the 103 degree Fahrenheit for the first 48 hours, and they will solve by the giving paracetamol. So this is a Stanford V regimen. This is for your information. But in the exam, if you write the ABVD is sufficient, ABVD is sufficient. Stanford V regimen. This is for your knowledge. Treatment of the non-Hodgkin lymphoma. Treatment of the non-Hodgkin lymphoma and the chronic lymphocytic leukemia include the same drug, chronic lymphocytic CLL, because they include the CHOP. Treatment of the non-Hodgkin lymphoma, it includes CHOP. CHOP includes cyclophosphamide, C for cyclophosphamide, H for hydroxydonorubicin, that is doxorubicin, O for oncovin. The another name of oncovin is vincristine, and P for prednisone. This CHOP also needs 6 cycles. CHOP every 14 days or CHOP every 21 days. So these four drugs regimen after every 21 days remains most commonly used regimen. For non-Hodgkin lymphoma, we have to prescribe the drug which will includes the four combination medicines after every 21 days. And for Hodgkin lymphoma, we have to give ABVD every after 28 days. So this is a treatment for the Hodgkin and the non-Hodgkin lymphoma. Hodgkin is ABVD, just remember the ABVD, 6 cycles every 28 days, and non-Hodgkin CHOP every after 21 days. There is one objective role of the steroid hormone for the treatment of the leukemia. What is the role of the steroid prednisone? Why it is generally given for the treatment of leukemia? Steroids are the drugs that act like the body's own hormone. They can help treat many types of cancer, and they can keep from having nausea and vomiting after a round of many chemotherapy, because the nausea and vomiting is the most adverse drawbacks of the chemotherapy. They can also prevent allergic reactions to other drugs, because we know that the steroid is an anti-inflammatory and anti-allergic drug. Prednisone is approved to be used to reduce inflammation and suppress the body's immune response. And some steroid doctor might prescribe, these are the prednisone, methylprednisolone, and dexamethasone for the long action. There is one objective in our block for the leukemia, mechanism of drug resistance to anti-cancer drug, because most of the drug causes resistance to the anti-cancer drug. There are many mechanisms of the drug resistance elucidated principally in vitro studies, and this includes mutation of target gene. Means what happened? Mutation means change in the genetic makeup. When our anti-cancer drug wish to target some gene, but this gene change their makeup and not able to identify by the drug, so develop the resistance. Amplification of target and mutated genes, same. There is an amplification and targeted gene, mutated gene which is not able to identifiable by the anti-cancer medications, cytotoxic medications, and it will develop the resistance. Differences in repair capacity, alter drug transport. Sometimes the drug is not able to reach to the site of action. If the drug is not able to reach to the site of action, development of the resistance, and differences in nucleoside and nucleobase solvase pathways. Nucleoside and nucleotide, these are the main targeting molecules in the management of the cancer. If they get difference, it will create the resistance for the drug. action. These are the main common mechanisms for the drug resistance, and that's why the cancer is not able to treat properly. So this was the objectives was remaining in yesterday's lectures. That's why I repeated today. So please go through it, read, and now we will move towards the main therapeutics cases of leukemia and the lymphoma. The first one is case 1. A 57-year-old patient with 6 years history of chronic lymphocytic leukemia is now receiving fludarabine for 5 days after worsening of his symptoms. He took previously 6 courses of chlorambucil. The physician commenced cotrimoxazole 960 milligram on alternate days. Now, fludarabine, yes, it is the most commonly, you should know the drug history. The fludarabine is the most important and commonly used single drug remedy for the treatment of the chronic lymphocytic leukemia. And chlorambucil, he took previously the chlorambucil, but there is no effect because the chlorambucil is not effective in the treatment of the CLL. And doctor given the cotrimoxazole. You should know the cotrimoxazole. Cotrimoxazole is antibacterial drug. Why doctor prescribe the antibacterial drug? Why the physician order to the above precautions? Cotrimoxazole, it is an the antibacterial antibiotics. Cotrimoxazole, it is an antibacterial antibiotics, and physician prescribe cotrimoxazole for the prevention of infection, pneumonia in patient with the leukemia. Because pneumonia, we can say it is one of the opportunistic infections, and it is generally observed in the patient with the CLL, that is chronic lymphocytic leukemia. For the precaution purpose, to prevent from the infections, physician or doctor prescribes the antibacterial medication, although the antibacterial medication is not a drug to treat the leukemia, but to prevent from the infections. We can say opportunistic infections may occur when the patient is having the leukemia and the lymphoma. Case 2, a 35-year-old woman recently diagnosed with chronic myelocytic leukemia, CML, attends to hematology clinic to discuss the option for treatments. Which treatments options are available? Now, for the CML, we are following 3 management steps. First one is the induction of remission. Second one is the consolidation. And third one is the maintenance. For the induction of remissions, what do you mean by induction of remissions? In the induction of remissions, after giving the drugs, there is an absence of all clinical and microscopic signs of leukemia. And imatinib is the most effective single treatment, or we can say standard first line therapy, or the combination therapy include cytarabine or hydroxyurea. What is consolidation? To eliminate residual leukemic cell. It is just for 1 week, but generally in the clinical practice, the consolidation therapy is not used. The induction of remission 4-week therapy is sufficient. And for the maintenance to prevent the reoccurrence in the chronic myelocytic leukemia, we will use same medications with but with lower doses. Same medications, imatinib or cytarabine or hydroxyurea. Which treatment is likely to be curative for these patients? Now, for the chronic myelocytic leukemia, the what is the success rate in the treatment of this chronic myelocytic leukemia by the medications, by the chemotherapy is low. The success rate is low. So, which is curative? To cure the patient, the allogenic bone marrow stem cell transplantation is the only curative therapy for CML. Allogenic bone marrow stem cell transplantation. Transplant the stem cell of bone marrow. It will cure the chronic myelocytic leukemia because the success rate with the medications is low. Case 3, a 40-year-old male on combination therapy for chronic lymphocytic leukemia developed hemorrhagic cystitis as a side effect of anti-cancer therapy. List the
Okay.
combination therapy that used in the treatment of this patient. For the chronic lymphocytic leukemia, we are using CHOP or COP. COP includes cyclophosphamide, O for oncovin, P for prednisone, and CHOP includes additional H, which is stand for hydroxydaunorubicin. Now, cyclophosphamide, name the drug the most likely cause this side effect, and we know that the cyclophosphamide is responsible for the hemorrhagic cystitis. And mention the drug that can be specially prevent the above mentioned adverse effect, and we know that in the lecture we studied the mesna. Generally, the mesna, we can say 2 mercapto ethane sulfonate is used for the prevention of hemorrhagic prevention and the treatment of the hemorrhagic cystitis. Mesna, to prevent the hemorrhagic cystitis. Case 4, a 40-year-old woman undergoing allogenic bone marrow transplantation for chronic myelocytic leukemia. Following transplant, she developed severe mucositis and gastrointestinal toxicity. She takes total parenteral nutrition, that is TPN. On day 16, she had temperature 38 degrees Celsius. An antibiotic therapy was initiated with aminoglycoside plus piperacillin. Aminoglycoside means the streptomycin, neomycin, kanamycin, gentamicin, amikacin, and piperacillin. Now we have less than a minute. This meeting will be discontinued. Please join again with the same link. 3 days later, after the taking the antibiotic, that is aminoglycoside and the piperacillin, the fever remain and the blood culture is negative. Blood culture is negative for this specific bacteria, but there is a fever. Daily blood count revealed persistence pancytopenia. What is pancytopenia? Decrease red cells, white cells, and platelets. This condition is called pancytopenia. IV amphotericin B is advised. Amphotericin. Now you should know what is the amphotericin. Amphotericin is antifungal antibiotic. What is the question? Why IV intravenous amphotericin B is advised? Amphotericin B is an antifungal antibiotic. It is used for the treatment of infection in patient with leukemia. Systemic antifungal given by intravenous route. If the fever, that is a pyrexia, persists